Good afternoon,
Yes,
everyone. Welcome to the Jaipur Surgical School, which is an afternoon extension of our morning online educational activity, Jaipur Surgical Tutorial. And in this, we do have presentations by surgical colleagues, but from time to time, we request colleagues from other departments, the related departments, to make a presentation. And today we are uh, fortunate and lucky to have Dr. Ravi Jain, who is my colleague in the Department of Critical Care Medicine, which looks after all our seriously ill patients. They also run a DM course in critical care medicine at my institution, the Mahatma Gandhi Medical College. And I have requested him to talk to us about nutrition, especially in critically ill patients, critically ill surgical patients. And I'm sure the same principles apply or would apply to other patients also, especially those who, for whatever reason, are not able to take or tolerate enteral nutrition. So with that brief introduction, I would invite and welcome Dr. Ravi to start his presentation.
Thank you, sir. Thank you so much for this kind gesture to invite and introduce me to this platform. I'll just introduce myself. I'm an assistant professor in Department of Critical Care Medicine at Mahatma Gandhi Medical College. We are going to discuss here today is the nutrition in critically ill patients. Though there are not much difference among the patients in critical care setup, but definitely surgical critical care patients have a different subset, and we'll focus more in the special case scenario in our presentation in that aspect later. So let's first, I'll just run through a brief of everything of this thing. It is a huge topic to discuss, and we have a couple of days seminar based conferences based on nutrition and critically ill patients. But we'll just summarize in a nutshell that the scope of seminar will be why to study nutrition at all, then how to screen and estimate nutrition demands, when to start nutrition therapy. That is the most important thing that we should know. Then delivery of nutrition, enteral or parenteral. We'll see the both of them, the indication, contraindication, limitations of both the things. Then special consideration and evidence base. If the time permits, we'll go further and have some discussion about refeeding syndrome, etc. also. So why to study nutrition? So bhuke pet na bhajan gopala. है ना? Nothing happens with empty stomachs. So in a brief, if I can summarize a few studies to quote here, in a large worldwide study, this is a large worldwide study which published that people are nutritionally sick, nutritionally challenged when they come to critical care, especially the surgical subset population. 20 to 46% of the patients are generally malnourished. Malnourishment further extends in the cancer patient because of the tumor-related etiology and malnutrition, like liver cancer, pancreatic resection, previous surgeries, stenosis of GI tracts, challenge, catabolism effects, etc., may lead to excessive malnutrition in cancer patients. Whereas our therapeutic interventions like chemotherapy, radiation, surgery, immunotherapy, this can also uh, lead the patient to the severe malnutrition. Further, the consequence of malnutrition. This is not a very new concept of malnutrition in critical ill patient. The notion for malnutrition affects surgical outcome was first reported in 1936 in the study that showed malnourished patient undergoing ulcer surgery had a 33% mortality rate compared to 3.5% in well-nourished individuals. And the significance was put forward by this study. This is one more uh, study which showed that nutritionally challenged patients in surgical subset population have a larger, uh, have a higher pulmonary infection, urinary infection, etc. complications. The malnutrition causes increased rates of infection. Well-nourished patients have 4.4 versus 14.6% nosocomial infection in severely malnourished patients. So it is, but obvious these are all Western data. So is our patient also malnourished in India? Definitely, we are not different from the worldwide population. And sorry, we are not different from the worldwide population. We have an at-risk population of 60%. Surgically patients are at risk, and 12.38% patients of surgical population are malnourished in our Indian data. These couple of studies published in the surgical subject population that further emphasizes the risk of malnutrition and negative outcomes. Like this one study, they said that the sarcopenia and postoperative complication risk in gastrointestinal surgical oncology patients. This is a large meta-analysis included 29 studies, 7,000 patients. Sarcopenia was associated with an
हमारे
increased
अपने
risk of
फैकल्टी पीएचडी कर रहे हैं।
जी सर।
इनको हमने नैक के लिए फुल टाइम निकाला है।
नहीं, पहले के लिए फुल टाइम नहीं है सर। एक्चुअली सर अपने पास में 23-24 से ही पार्ट टाइम कोर्स इंट्रोड्यूस हुआ है। उससे पहले फुल टाइम नहीं था, कोई भी एडमिशन ले।
तो जब हमने एडमिशन लिया तो उस समय पार्ट टाइम की कोई बात नहीं।
Yeah, so this is a huge, this was a huge population which validated the concept of malnutrition. Sarcopenia was associated in this study with increased risk of postoperative major and total complication in patient undergoing surgery for gastrointestinal cancers. Further, one more meta-analysis that shows to decrease the postoperative infection and non-infectious complication and also length of stay patient undergoing gastrointestinal surgery. The postoperative nutrition supplementation is imperative. Further, how this all happens. So, whenever a patient suffer from malnutrition during the catabolism phase of critical illness, or we can say in this context, surgical critical care patients, there is an acute phase response which leads to altered amino acid distribution and metabolism, which leads to increased globulin synthesis, increased gluconeogenesis, decreased iron store and zinc stores, further decreasing essential other serum proteins. Catabolism with increased urinary urine nitrogen excretion further leads to depletion of nitrogen, tilts the nitrogen balance towards the negative side. Then there is vast hormonal challenges like insulin resistance will happen, rise in serum cortisol, catecholamine will lead to decreased glucose oxidation, increased hepatic glucose production rates, and fatty acid oxidations. It will ultimately lead to sickle thyroid syndrome also, and patient get malnourished later on. So the effect of malnutrition in surgical patient, we can see that impaired organ function will lead to respiratory, cardiovascular, and uh, red blood cells. Effect on red blood cells which will reduce the oxygen supply, and impaired wound healing will further ensue. It will lead to impaired collagen synthesis also, which will reduce the wound strength. Impaired immune function will reduce the increased risk of infection. Reduced antioxidant activity will lead to increased free radical damage. Will ultimately lead to impaired wound healing in surgical substance. So malnutrition increases length of stay in surgical critical care patients. Also, ultimately, this will lead to these kind of complications that we can see in our day-to-day practice. Wound gapping, sores, non-healing ulcers, poor nutrition status will lead to diffuse edema at the surgical sites, leakage of anastomosis, and poor outcomes ultimately. So, how to screen and estimate nutrition risk and needs? This is again the goal of the nutritional assessment is to identify patient at risk for increased morbidity and mortality due to poor nutrition. So, subjective global assessment, you can use clinical parameters like history, physical examination. This will determine the cause for restricted nutrition assimilation, decreased food intake, maldigestion, malabsorption, etc. Effect of malnutrition on organ function, influence of disease process on nutritional requirements. Further, we can go ahead and we can go ahead and take anthropometric measurements like height, body weight, etc. But these are not that reliable in critical care subsets because we do not know most of the time what the previous situation was. The biochemical data we can also take in account like serum protein, serum albumin. Serum albumin is many times we have seen that in practice people believe that serum albumin is a marker of nutrition. Status of nutrition, but in case of visceral and somatic protein stores is only that is indicated by albumin concentrations. Hypoalbuminemia in critically sick patient will be because of overhydration, increased catabolism, decreased synthesis in the liver disease patients, and increased loss because of the wounds, large wounds, burns, etc. Serum albumin levels serve as a poor marker for initial nutritional state. It also does not serve as a marker for improved nutritional state following nutritional support. So it's not a good marker to rely upon. Further, serum transferrin, thyroxine binding pre-albumin, retinol binding protein, fibrinectin. I have written the half-life of these different markers over here. But can be used as a marker for improved nutritional status? No, not definitely. These are the inflammatory markers, or can be taken as a acute phase reactants in critical sickness. Although many studies have been done, and none of the studies proven to be proven to prove to validate these markers for the nutritional status assessment. And one major limitation: these are costly markers. Semaglutide, renal and hepatic function tests, pulmonary function tests, etc., can also be used, but not that reliable for the particular nutritional assessment part. So we have multiple scores for that risk assessment purpose. Options are MUST score, NRS 2002 score, Nutrix score, etc. Among all the screening tools, NRS 2002 and MUST tools have the strongest predictive value for mortality, and they have easiest and quickest way to calculate. Easiest and quickest to calculate among the many tools assessed. Like here, I have given example of MUST tool. There are 5 steps in MUST tool that you need to ascertain. Step 1 looks after the BMI score. Step 2 looks after the weight loss score. Step 3 looks after the acute disease PET score. In the step 4, overall risk of malnutrition is assessed. Add scores together of step 1, 2, and 3 to calculate overall risk of malnutrition. Score 0 is low risk. Score 1 is medium risk. Score 2 is more 2 or more is high risk. Then we go to the step 5 and ascertain if the patient is at risk of malnutrition or not. Similarly, you can see a very easy to calculate NRS 2002 score, where the components are nutritional status, 0, mild, moderate, and severe can be classified as. Then weight loss, with the history of they take in account the history of weight loss. If history of weight loss is more than 5% in the last 3 months, the nutritional status is mild, scored as mild. 50 to 75% normal food intake. This will give 1 point again. Moderate will get weight loss more than 5% in 2 months, or BMI 18.5 to 20.5 kilogram per meter square, or reduced general condition, or 20 to 50% of normal food intake in last week. This will get a score of 2. If patient is severe condition, weight loss more than 5% in 1 month, BMI less than 80.5, 0 to 25% of normal food intake in last week will be categorized as severe nutritional status and then scored as 3. Advanced age will get, or more than 70 years will get a score of 1 automatically. Severity of the disease, stress metabolism, mild, moderate, and severe, 0, 1, 1, 2, and 3 points will be allocated according to the severity of the disease. If 0 to 2 points are scored in NRS 2002 score, then we need to repeat the screening weekly, and patient is considered as low risk for nutrition. If the 3 to 7 points are there in the score, then patient is a nutritional risk, or nutritional care plan should be immediately started. Similarly, a Nutrix score also, whereas age, comorbidity, days from hospital to ICU, Apache score, SOFA score, interleukin 6, take different scoring, and the score is calculated as 0 to 5. If low Nutrix score, high, if 6 to 10 points are there. If high Nutrix score is there, then the patient definitely needs nutrition care plan. Although, let's see what the ESPN guidelines, the European Society of Parental and Enteral Nutrition guidelines say in 2023. If patient is in ICU for more than 48 hours, is considered as risk for nutrition already. Okay, there's a very strong consensus about this thing. Medical nutritional therapy should be considered in all patients staying in ICU, maybe for more than 48 hours. Support general clinical assessment to assess malnutrition in ICU. Until a specific tool has been validated, they say this categorically that none of the above written biomarkers or the scores have been well validated, and none of these should be relied upon in a without any in a unison. Okay. They put a remark over there that the general assessment, anamnesis, report of unintentional weight loss or decrease in physical performance before ICU admission, physical examination, Then assessment of body composition and muscle mass and strength, if possible, should be taken in consideration to ascertain the risk for nutrition. So while we estimate the risk of nutrition, after that we need to see how to estimate the nutrition demand. So most reliable tool. This is the crux of the story. What I am going to tell further. Most reliable tool is indirect calorimetry. In ventilated patient, this is the most reliable tool for nutritional assessment. Then second best approach is through, though mostly it overestimates, resting energy expenditure estimates via the carbon dioxide elimination, estimates by ventilation. After that, least complicated and most used is the simple weight-based equations that we use in our ICUs mostly. Let's see them one by one. Calorie requirement by indirect calorimetry. This is the most preferred or most reliable method of ascertaining the resting energy expenditure. This is done by metabolic cards. Specialized metabolic cards are there. They see oxygen consumption, VO2, as well as CO2 production, carbon dioxide, VCO2, and ventilation. Then they put this thing in the formulas and calculate the resting energy expenditure. They exactly measure calorie needs in critically ill patients. Then if the patient is at rest, there is a limitation that it underestimates the calorie needs by 10 to 15%. Further, to mention a few, it is expensive, it is time consuming, you need a specialist to look into it, the calorie requirement by indirect calorimetry. It is not universally available everywhere, it is costly. It becomes unreliable if the patient is having high FiO2 more than 60% and high peak more than 12 centimeter of H2O, and if there is leak in sampling. Okay, so indirect calorimetry is very limited in our Indian used very limited in a very limited way in our Indian ICUs. Then see volumetric capnography, second best, though mostly it overestimates the resting energy expenditure from the exhaled carbon dioxide obtained from ventilators. It is directly VCOD is directly multiplied by 8.19 factor, which gives us the resting energy expenditure. Limitation: it is not accurate. Definitely needs ventilation and volumetric capnography instruments in place. The nutritional requirements by taking in account of weight or height-based equations. One of the very famous equations is Harris-Benedict equation for resting energy expenditure. For males and female, you can see on the screen that two different equations are there, whereas W is weight in kgs, height in centimeters is h, A is the age. You calculate the resting energy expenditure, then total energy expenditure will be calculated as further to add activity factor, disease factor, and thermal factor to the to multiply with resting energy expenditure like this. If the patient is at bed rest, 1.2 factor is multiplied. If it is out of bed, then 1.3 factor is multiplied. Disease factor, as you can see over here, burns, take the account, take most of the, sorry, yeah, burns, uh, the requirement goes up when the patient is having severe disease like general surgery, sepsis, multi-organ failure, 30 to 50, 50 to 70, and 70 to 90% burns. Okay, so these factor needs to be multiplied with the resting energy expenditure, and you get the total energy requirement. You can also have a Kevin-Lox stress factor concentration catabolism. And most critically ill patient will need 25 to 35 kilocalorie per kg ideal body weight of calories. This is the most simplest way that we can by which we can calculate the energy requirement in critically sick patients. Though it overestimates most of the time, so that the guidelines have modified their targets, the initial targets for critical for nutritional supplementation in these patients. So calorie requirement, this is a smart table which we can refer for calorie and components requirement, macronutrient requirements for critically sick patients. Total calorie, 25 kilocalorie per kg per day. Initial requirement for a 60 kg adult is also calculated in this table. Protein and peptides and amino acid, 1 to 1.75 gram per kilogram per day, 15 to 25% of total calorie requirement. Carbohydrate, 3 to 3.5 gram per kg per day, 40 to 60% of total calorie requirement. Fat is 0.75 to 1 gram per kilogram per day, 20 to 30% of the total calorie requirement. It should be supplemented in this way in whatever the mode you choose to deliver nutrition to the critically sick patient. Water and electrolyte, these are again one important components. 25 ml per kg dry body weight of fluids to avoid dehydration should be supplemented daily. Okay, others 1 milliliter, roughly it goes down like this. 1 milliliter of per kilocalorie consumed should be provided. 1 milliliter of fluid should be provided for per calorie consumed. For infants, the fluid requirement is little higher, 1.5 milliliter per kilocalorie consumed. Potassium, magnesium, phosphorus, zinc in amounts to maintain normal serum levels should also be supplemented while we provide nutrition to these patients. RDA for all vitamins and minerals usually provided is just usually provided in the pre-prepared formulas, 1000 to 1500 ml of pre-prepared enteral and parenteral formulas also. These are already there in our recommended daily allowance forms. Like mineral requirement, you can see over here in this table, the sodium 90 to 150 milliequivalent is daily requirement of the sodium. Potassium is 60 to 90 daily requirement is there. Magnesium is 350 milligram daily required. Calcium is 1000 milligram. Phosphorus is 1000 milligram required daily. In this table, we should also understand that uh, electrolytes like potassium, magnesium, these are the intracellular electrolytes. If there are deficiencies there in the lab reports that we need to monitor daily in critically sick patients, then the requirement will be much higher because these are intracellular ions and we take samples from serum only. So we need to supplement these ions accordingly. Let's see when to start nutritional therapies. This is one contentious topic. Sometimes we feel that surgical patients or post-surgical patients need can be delayed on nutrition part, or we can challenge them a little bit higher for the safety of for the sake of safety of our surgical part, or to avoid aspiration risk. So consider nutrition therapy in all critically ill patients, especially first 48 hours, if it is more than 48 hours in ICU. ESPN guidelines categorically says that oral diet shall be preferred over enteral nutrition or parenteral nutrition in critically ill patients who are able to eat. Whenever the patient is able to eat, provide oral diet. If oral is not available or oral cannot be provided, then enteral nutrition within first 48 hours, rather than delaying enteral nutrition or providing early parenteral nutrition. That means that we should not delay enteral nutrition and we should not hurry in providing parenteral nutrition. Both the things. Early enteral nutrition can be provided safely in patients who are on ECMO, patient who is of traumatic brain injury, stroke, heart injury, GI surgery patients, GI surgery patients, abdominal aortic surgery patients, trauma, patients who are on neuromuscular blocking agents, patients who are prone for some for ARDS users, patient who has open abdomen, absence of bowel sound, not when the intestinal obstruction is there, definitely, but absence of bowel sound is not a contraindication to providing enteral nutrition. Diarrhea, certainly we'll see later. The diarrhea is also not a contraindication for enteral nutrition. Avoid overnutrition and achieve goals progressively, not before the first 48 to 72 hours. As I told you earlier, that the estimate that we make 25 to 30 kilocalorie per kg per day is overestimating the nutritional requirement in critically sick patients. That's why it is said that we should not achieve 100% of the target in first 48 to 72 hours. Not able to. Yeah. So let's see. This is when we need to provide nutrition early. Let's see when we need to provide nutrition delayed. So when the patient is having uncontrolled shock, that means patient is not able to maintain hemodynamics with appropriate management of resuscitation and providing adequate amount of vasopressor agents. If that is the case, then we should definitely delay it for a while to achieve a target of hemodynamic. Then we can start not target based, but definitely a trophic feed. 400 to 600 kilocalorie per day feeds can definitely be provided. Refractory life-threatening hypoxemia, hypercapnia, then definitely you can provide feeds, trophic feeds, not the target-based feeds. If patient is having abdominal compartment syndrome, patient is having active upper GI bleed, patient is having bowel ischemia, Patients having gastric residual volume of more than 500 ml for 6 hours, then definitely we should look again towards our strategy to provide enteral nutrition. If patient is having high output intestinal fistula and there is no distal access to provide nutrition, then definitely we can delay enteral nutrition for a while. Let's see enteral versus parenteral nutrition. So, if we have a functional, so by thus far, we are clear that if we have a functional gastrointestinal tract, then definitely we should provide enteral nutrition. If that is not the case, then we can go ahead and use parenteral nutrition. If the ball works, use it. It is more physiologic, it is safe, inexpensive, it preserves gut integrity, it provides barrier and immune function, it nurtures the barrier and immune function, supplies gut preferred fuel like glutamine, glutamate, and short chain fatty acids, unlike standard parenteral nutrition. It prevents the development of cholic acid by stimulating for better motility. Initiation within first 48 hours of isolation in hemodynamically stable patient is the uh, recommended treatment. Reduced enteral stimulation leads to decreased Peyer's patches and leukotrienes secretions, reduced T cell, B cell, and Peyer's patches lamina propria and uh, epithelial thickness, reduced secretory local immunoglobulins and altered cytokine sequence. It leads to mucosal atrophy. It leads to altered GI, gastrointestinal bacterial and microbiological flora. It reduces the gastric acid secretion, which ultimately provides us the barrier for microbial colonization. It leads to more and more of bacterial translocation. This is the most dreaded complication that we face while we reduce the enteral nutrition or while we restrict enteral nutrition. There are some relative contraindications to enteral nutrition, like GI causes, severe diarrhea, paralytic ileus, intestinal obstruction, acute pancreatitis, high output external fistula, but definitely you should take this contraindication with a pinch of salt and try to feed the patient most of the time by enteral route. Yeah. So these are the various routes by which we can provide enteral nutrition: oral, nasogastric, nasoduodenal, nasojejunal, percutaneous feeding gastrostomy, or jejunostomy tubes. ESPN guidelines say categorically that we should approach by providing gastric nutrition as a standard protocol. If it is not tolerated and patient is having high risk of aspiration, then we can go ahead and provide post-pylori feeds, vaginal feeding, if the patient is at risk of aspiration and intolerant to gastric feeds. They say categorically that continuous feed is more preferred than the bolus feeds, like we give it twice hourly mode or something like that. That is not preferred. There is limited amount of data, although I have put two question marks over there. There is limited amount of data that suggests that bolus and continuous enteral feeding can achieve the same target without an increase in side effects in any of these routes. So you can use according to your preference, but definitely bolus feeding could provide a greater stimulus for protein synthesis. So there is competition between these two things, and the verdict is not out in clear forms. Gastric feeding, stomach initiates the digestion. That is the most advantageous part. Gastric acid secretion, cellular gastric contents. The stomach protects the gut from osmotic load also. It leads to excessive sequestration. Disadvantage: patient can develop gastric atony. Risk of aspiration of gastric content is always there. Monitoring gastric and residual volume every 2 to 4 hours is mandatory. It was earlier mandatory, not nowadays mandatory. So starting tube feed, how do we start? Test infusion with volume of NS equivalent to the hourly feeding, volume infused into stomach. Then clamp the tube for 30 minutes and residual volume is aspirated. If volume aspirated is less than 50%, gastric tube feeding is started. If during feeds residual volume increases, or if you find that there is vomiting or kind of paralytic ileus is developing, then give feed at a slower rate after giving prokinetic agents, or temporarily stop for a while. Not withhold for a long duration. Try to maintain enteral nutrition as far as possible. Then they recommend in the ESPN guidelines that in ICU settings, evidence of bowel motility, presence or absence of bowel sounds or passage of flatus or stool is not required to initiate enteral nutrition in ICU. You should not look for these things in a unison. You should not look for these things in total to avoid or to provide feed. Holding enteral nutrition for GRB less than 500 ml in absence of signs of intolerance should be avoided. Attempt to make enteral feeding more tolerable than withholding. Always. Let's see the complications of enteral feeding. There can be many complications of any approach that we provide in our ICUs, such as enteral feeding also. Gastric retention, vomiting and aspiration. More often with gastric feeding, incidence varies from 1 to 44%. But definitely we should be more careful while providing feeds. Mechanical problems like feeding tube obstructions. You can flush the tube with water before and after infusion of nutrients. If tube block can't be flushed, then remove the tube. Malposition of the tube. Malposition of the tube is one serious thing that we should look before starting any kind of feeding by enteral nutrition. Tube position into the GIT should be confirmed by radiographic assessment. Note, auscultation findings can be misleading most of the time or many other times. So tube placed in base of the left lung can produce similar sounds than tube placed in stomach. So we need to be careful before assessing by auscultation only. Diarrhea is one of the troublesome complications. We should take steps to control diarrhea, like reduce the feeds by half, avoid lactose or bolus feeding, use pectin or cavulation with aluminum hydroxide, use isotonic solutions more and more. Stop any diarrhea causing antibiotics and magnesium to make it more to make enteral nutrition more tolerable. Sinusitis, otitis media, if the tube is placed in your nasal route. Metabolic complications like hyperglycemia and diabetes. Uh, we need to provide insulin therapy for that. Severe hypophosphatemia or hypokalemia can also be there, so we need to provide supplements for that. We need to monitor them rigorously. Dislodgement of gastrostomy or xenostomy tube is a rare complication and a mechanical complication. Let's come to the parenteral nutrition part. In case, so the ASPN guidelines provide these four statements for parenteral nutrition. This is a very important part. In case of contraindication to oral or enteral nutrition, parenteral nutrition should be implemented within 3 to 7 days. Okay, parenteral nutrition should not be started until all reasonable strategies to improve enteral nutrition tolerance have been attempted. If gut if early and progressive parenteral nutrition, if contraindication for enteral nutrition and severely malnourished patient. If the patient is intolerant to full dose of enteral nutrition during the first week, safety and benefits of initiating parenteral nutrition should be weighed on case-to-case basis. These are the four guiding principles that leads to our parenteral nutrition strategies. If gut is available, use the gut. If gut cannot be used now, wait for 48 hours or at least make it work, make it function, and then use parenteral nutrition. If the patient is severely malnourished or patient is at high risk of malnutrition, then definitely on case-to-case basis, you can use parenteral nutrition. So these are the salient indications that you may find in various textbooks about parenteral nutrition that impair obstruction of the nutrients, enterovenous fistula, short bowel syndrome, short bowel obstruction, effect of radiation and chemotherapy, need for bowel rest. If there is need for bowel rest, severe pancreatitis, inflammatory bowel disease, ischemic bowel peritonitis, pre and post-op status, motility disorders, if they are there, like prolonged ileus. But definitely you should take these indications one by a pinch of salts. Okay. Parenteral nutrition is very dangerous if it is unmonitored, if it is provided without any specialist consultation. It can be deleterious. If there is inability to achieve or maintain enteral access, patient is hemodynamically unstable, massive GI bleeding is there, unacceptable expiration risk is there, hyperemesis is there, then definitely we can look for case-to-case basis about parenteral nutrition. How do we do that? So selection of macronutrients, indication of only dextrose-containing crystalloids. If patient is unable to take orally less than 1 week, not malnourished, stable, and no need for nutrition support, then definitely you can go ahead and give dextrose with vitamins and minerals. It's the mainstay for post-operative patients, immediate post-operative patients. It provides calorie, has nitrogen sparing effect also. So before delivering parenteral nutrition, we should look for these three things: roots, peripheral versus central, what we need to select; system, multiple bottle system versus 3-in-1 solution system; duration, continuous infusion versus cyclic infusion. So root, definitely there are now options available, commercially prepared preparations available for peripheral parenteral nutrition. They deliver all the required nutrients through the peripheral veins. The difference between peripheral and central nutrition is light. Osmolarity of peripheral parenteral nutrition is less than 900 milliosmol per liter that can be tolerated in peripheral veins. It is low concentration dextrose solution, amino acid plus concentrated calorie dense lipids are there. Peripheral veins should be accessible and patients should be able to tolerate parenteral nutrition in large volumes. So we need to give large volumes to meet the calorie demands of the patient. Central nutrition, definitely. Most efficient way to deliver all the nutrients by central venous catheter insertion by SVC or ICE, superior vena, subclavian vein, superior vena cava, or inferior vena. Composition, very compositions can be there. 50 to 70% of dextrose, amino acids, osmolality is very high for the central parenteral nutrition. Osmolality is very high for central parenteral nutrition. But definitely you can meet the calorie demand in very small volume also. So this is a way to calculate daily requirement of nutrition. Fluid requirement 35 ml per kilogram. Then calorie requirement 25 kilogram, 25 kilocalorie per kilogram. Protein requirement 1 gram per kilogram. Fat requirement 30% of the total calories is the total fat requirement. Carbohydrate requirement is calculated as such 1500 and so on. So this is one way to judge that how much nutrition do we need to give to our particular patient. Then you can see the commercially prepared formulas for the volume that is required per day to meet the nutrition requirement. So how do we initiate after that? Initiate parenteral nutrition slowly with volumetric infusion pumps most of the time. 50% on day one of the total nutrient requirement should be given. On day two, 75%. Achieve 100% slowly over the 3 to 7 days period. Most patients tolerate 3 liters of solution per day in parenteral nutrition form. Monitoring is very important for prevention and early detection of complication to judge effectiveness of the therapy. Clinical data that we monitor daily for parenteral nutrition is history, fever, fluid overload, history suggestive of fluid overload, glucose and electrolyte imbalance, vital signs, temperature, heart rate, blood pressure, respiratory rate that we monitor daily in our ICUs, fluid balance, intake output chart, weight chart, local care, inspection and dressing of the vascular access site is also important. Delivery system, inspection of solution for contamination and functioning of the infusion pump should also be monitored daily. Laboratory data like fingerstick glucose test, blood glucose, sodium, potassium, chloride, bicarbonate, blood urine nitrogen, liver function test, serum creatinine, albumin, phosphorus, calcium, magnesium, phosphorus, hemoglobin, hematocrit, WBC counts, clotting test, micronutrient test. Whenever it is indicated, we do it. Frequently, we do glucose test, definitely, and other electrolytes test we do daily. Monitoring the response to nutrition therapy, improving clinical status, protein concentration, albumin, pre-albumin, fasted, these are improving, then definitely your therapy is functioning. When to terminate parenteral nutrition? If you are able to restart oral or enteral food intake as soon as GI function improves, then stop the parenteral nutrition altogether. Gradual transition from parenteral nutrition to oral enteral nutrition should be done. In that case, reduce infusion rate to 50% in 1 to 2 hours before stopping. Minimize the risk of rebound hypoglycemia. This minimizes the risk of rebound hypoglycemia. When 60% of total energy and protein requirements are taken orally and early, parenteral nutrition may be stopped. Complications. Coming to complications, these are many complications, few of the many complications that parenteral nutrition can exhibit. Okay, in first 48 hours, I'll not go to the mechanical complications because these are the catheter-related and catheter-related or exercise-related complications, but we go to the metabolic part mostly. First 48 hours, patient may have fluid overload, hypoglycemia, hypophosphatemia, hypokalemia, hypomagnesemia, and repeating syndrome. After in the first couple of weeks, hypoglycemic coma, acid base and electrolyte imbalances, catheter site infection, sepsis, exit site infection can be there. If the patient is using very long-term parenteral nutrition, then essential fatty acid deficiency, vitamin or trace element deficiency, metabolic bone disorder, liver disorder can be there. Tunnel infection, catheter-induced sepsis, exit site infection are the most dreaded complications in these patients. Let's see the special consideration We'll go to this forum about the surgical, about the nutrition delivery in surgical patients. ESPN guidelines have given nutrition-specific guidelines for nutrition in surgery. And you are, I think, familiar with this particular flow chart of providing ERAS protocol, early recovery after surgery protocol that uh, inserts some components of the nutrition part also in the early recovery for the early recovery part. Key aspect of the perioperative care is avoidance of long period of pre-operative fasting, re-establishment of oral feeding as early as possible after surgery, integration of nutrition into overall management of the patient, metabolic control, example blood glucose, reduction of factors which exacerbate stress-related catabolism or impair gastrointestinal function, and provide early mobilization to the patients. These are the key aspects. In perioperative, they answer 3 or 4 questions categorically in their guideline. First, perioperative fasting is necessary or not. Perioperative fasting from midnight is unnecessary most of the time. So what they say that the patient undergoing surgery who are at risk who are considered to have no specific risk of aspiration can bring clear fluids or clear dextrose water at least 2 hours before anesthesia also. Solids are allowed until 6 hours before anesthesia. We say categorically that this approach provides better insulin control, better metabolic control of the patient, and less negative nitrogen balance in the starting the surgery. Is perioperative uh, uh, mission notification using carbohydrate treatment is useful. Instead of overnight fasting, pre-operative carbohydrate loading the night before and 2 hours before surgery is recommended in most patients undergoing major surgery. Yeah. So again, they say inadequate oral intake for more than 14 days is associated with higher mortality. Enteral nutrition is therefore indicated even in patients without obvious undernutrition if it is anticipated that the patient will be unable to eat for more than 7 days perioperative. It is also indicated in patients who cannot maintain oral intake above 60% of recommended intake for more than 10 days. The enteral route should always be preferred except for the following contraindications like intestinal obstruction or ileus or severe shock, intestinal ischemia, etc. So for the question number 4, following is it beneficial? Early initiation of normal food intake or enteral feeding is recommended after gastrointestinal surgery. When anastomosis of proximal gastrointestinal tract have been performed, enteral nutrition can be delivered via a tube whose tip is distal to the anastomosis. These approaches can be taken care while providing nutrition in surgery patients. So early nutrition, they say in this study that early versus traditional postoperative feeding in patient undergoing restrictional gastrointestinal surgery, they say that early postoperative nutrition is associated with significant reductions in total complications compared with traditional postoperative feeding practices and does not negatively affect outcomes such as mortality, anastomotic dehiscence, resumption of bowel function, and hospital length of stay. Bowel sounds, not mandatorily, we should not look for bowel sounds, are not associated with flattest bowel movements and tolerance of food oral intake after major abdominal surgeries. So there is multimodal enhanced recovery after surgery is an integrated multidisciplinary approach that requires participation and commitment from patients, surgeons, anesthesiologists, pain specialists, nursing staff, and all the people involved in the perioperative care of the patient. So this is the integrated approach bundle that you provide while providing ERAS protocol to our patients. So focus on nutrition and surgery will lead to improved patient outcomes. So this should be our commitment. To summarize this talk, metabolic response to stress is characterized by catabolism, hypermetabolism, hyperglycemia, and enhanced lipolysis. Counter-regulatory hormones, cortisol, glucagon, catecholamines, and cytokines are major mediators of this response. During acute phase of illness, patients unable to eat should receive enteral or parenteral nutrition support. Nutritional support during acute phase of illness is designed to provide patients suffering from metabolic disarray with sufficient nutrition to add biochemical functions and attenuates further loss of body mass. Only once Only once the ravages of stress response have abated can the lost lean and fat mass can be depleted. Overfeeding and aggressive refeeding should be avoided on this. So here I think I'm ending my talk. It's already time. Thank you, sir.
Thank you. Thank you, Ravi. Thank you very much. Actually, don't be disappointed when you see only 3 or 4 participants, because what is happening that in the live session, very few people join, but as you would see later, a large number of students and surgeons watch these videos when we post them on YouTube. So I'll keep you posted about it. And whatever you have presented will be useful to the surgical students. I'll just check whether there are any questions on the chat. Otherwise, we will probably.
I think.
Thank you. Thank you very much. Thank you. All this will be recorded by the team in Ahmedabad.